Hey everyone, thank you so much for joining us tonight for our webinar on how to successfully diagnose and treat TMD. Also tonight, I just wanted to outline what we'll be going over, the difference between occlusal-muscle disorders, intracapsular disorders, and orofacial pain-related disorders, how to diagnose the problem accurately, when and how to use splint therapy for suspected TMJ disorders, how to approach TMD patients with restorative and aesthetic needs, and finally, an overview of airway diagnosis and its importance as a consideration in treatment. I'm Virginia, and I will be the moderator tonight. But tonight, our instructor will be Dr. Andrew Cobb. I'm so thrilled to have you, Drew. Drew is our director of the core curriculum. He's also a senior faculty member for the Dawson Academy after joining the faculty in 2005. And he actually started as a student of the Dawson Academy years ago. Beyond overseeing and developing the content of the core curriculum, he teaches several lectures, one of which is a TMD course, and also our introductory course of functional occlusion from TMJ to smile design. Dr. Cobb also practices himself in Washington, D.C. full-time and sees a lot of TMD patients, as you will hear tonight. So Drew, thank you so much for joining us tonight. I'm going to pass over the reins to you.
Thank you very much. Thanks, Virginia. Great to be here. And we're going to try to give you a broad swipe overview of how to successfully diagnose and treat the TMD patient. There's certainly a lot of facets to this patient. And, you know, it's a patient that years ago, when I first started taking the Dawson curriculum in the mid-90s, that Dr. Dawson said, you will see these patients. And once you learn to identify and diagnose these patients, who better to treat them than the person that can actually diagnose this type of problem. So let's kind of get started. And there's a lot going on potentially with a TMD or a symptomatic patient. But let me ask you something. So this is Daniel. What would you do now, and what are your protocols in your office if Daniel was a new patient to your office tomorrow? And in your conversation with Daniel on why he came to see you, just reviewing what we refer to as the preclinical interview, and we'll talk about our processes in a little bit more detail in a bit for those that aren't familiar with them. But the preclinical is just basically the question and answer. Why did the patient come? We do these things before we actually start to do the examination. But just in talking with Daniel, this is your new patient, this is what he says. He feels a constant dull ache that's pressure-like. He's been dealing with this for at least 3 years. His teeth feel like they're being pushed out of the gum. It's worse in the morning and at the end of the day, but it's consistent every day. The sensation all day interferes with his concentration. He has his own IT company, and he said by 4 o'clock, he just cannot work anymore. He's seen 2 neurologists already, and they've given him gabapentin, which is Neurontin. So it's used for neuropathic pain, seizures, anxiety disorder, bipolar depression. And with these meds, the downside about these meds is there's a lot of side effects: dizziness, fatigue, drowsiness, tremor, sexual dysfunction, and an increased suicide risk. He's obviously trying to get help. He's on the medical side of things. And, you know, unfortunately, maybe rather than just a diagnosis, he's given medications. He saw another neurosurgeon to rule out trigeminal neuralgia. He doesn't have that. He's seen an oral surgeon who recommended clonazepam or Klonopin, and again, it's a benzo, basically a tranquilizer, again used for seizures and panic disorder, muscle disorder, but again, a lot of side effects, and again, one of them is dependence. And think of where we are now in the medication world. We're trying to get patients off of this type of medication. The GARD he got relief with the GARD, but it was just a store-bought GARD, so it probably didn't help. And you'd hope that a medication like that gets him some relief, but he was kind of dependent on the medication. He also says that chewing gum helps, and it's a sensation's getting worse slowly over the years. And he's driven 4 hours to see you. So my question, I guess, is if this were your patient, what would you do? What would your next step be? Do you think we can help Daniel? Or is there too many other things going on? So we'll talk about Daniel again later, but I do want you to just take a few seconds and just think, if this happened in your office tomorrow, do you have the protocols in place to at least kind of figure out, is this a problem that we can affect change and maybe help Daniel, or is it something that's not in our realm of treatment possibilities at all? So let's talk about TMD a little bit. And you're not going to practice dentistry without seeing TMD patients. As a study from JADA, 10 million Americans suffer from TMD-related symptoms, 12% of the population. This was a study of almost 46,000 households, and 22% experienced an orofacial pain-related problem in a 6-month period. And odontogenic is the most common, but also non-odontogenic pain was commonly reported. Another study that a lot of these patients with TMD-related symptoms, 75% reported neck pain, 72% reported back pain. The dilemma with that is a lot of times it's not just one thing, but they could have symptoms coming from different areas in the head and neck area. Another JADA study, again, 1 in 6 visiting a GP experienced orofacial pain. Dental alveolar and musculoligamentous muscles, ligaments, and joints are very prevalent. Pain in the muscles and TMJs was found as frequently as teeth. And this was kind of interesting, is training is needed to better identify orofacial pain. It is a very teachable procedure. Another study, 22% of the population suffering from orofacial pain in the last 6 months. So what is TMD? There's a lot of definitions out there with various degrees of accuracy. We'll go back to what Pete wrote in his book. It seems to be the most accurate for our purposes. Temporomandibular disorders, any disorder that affects or is affected by deformity, disease, misalignment, or dysfunction of the temporomandibular articulation. And as dentists, this is in our realm of what we need to be able to identify and diagnose if there's a problem here. According to the guidelines and assessment from the American Academy of Orofacial Pain, TMDs also include disorders involving the masticatory system or the joint. They've been described as a major cause of non-dental pain in the orofacial region. It's pain associated with the hard and soft tissues of the head, face, and neck. Tissues in this area send impulses through the trigeminal nerve. And because of this, there's a diverse potential for pain arising from different trigeminal receptive fields. And sometimes then this will require collaboration among all fields of medicine. These are some of the problems with the more complex patient, that it's not necessarily all from areas we can affect, but the pain sources can be coming through receptive fields in the trigeminal nerve area. Something Pete has said again is TMD is not a multifactorial disorder, but it consists of many disorders, each of which can be multifactorial. We'd love to be able to identify one problem, you fix that problem, and everything goes away. With the TMD patient, a lot of times it could be a number of things, each causing symptoms. And so it's more than one thing maybe causing the symptoms or discomfort with the patient. But every time we can take off a layer and we can make that patient feel a little bit better, we're heading in the right direction. And maybe all of the layers aren't dental. But again, what we're responsible for, if we can affect change and improvement on those, we're going to help the overall health and feeling of our patients. So let's simplify a little bit. There's kind of 3 things that we got to start looking at: Occluso-Muscle Disorders, Intracapsular Disorders, and then outside of kind of the dental field, orofacial pain-related disorders, and we'll further subdivide that in a minute. But that's basically our area and the things we have to answer. Is it a muscle problem? Is it joint? Or is it outside of that and it's an orofacial pain problem? Starting points, couple key points. We always want to assess the health of the joints. And if there is a disc derangement, by that we mean if there's something going on inside the joint and the cartilage or the disc is out of place, it's critical to distinguish whether that disc is completely or partially off of the lateral pole. It's a different complexity to the treatment for a completely displaced disc. And we have to realize that if the joints are unstable, the occlusion's unstable. Now, the important thing about that is we do not want to do definitive dentistry on a patient that has unstable joints, because as dimensions change at the joint level, that means the occlusion is going to change. So just picture for a minute if you did some restorations or extensive restorations or orthodontics, whatever it is, and you could end up with what you think is a great result. But if changes are still happening at the joint level, the occlusion will change. It's not stable. It's like building your foundation in quicksand. So we don't want to do irreversible dentistry until we know and can verify that we have stable joints and the patient's comfortable and the occlusion's not changing. We don't want to get tunnel vision for occlusal therapy. Again, something that I heard Pete say years ago, and once we start, and I know I did this, but once you start kind of looking for these problems, it looks like everything is that problem. So you got to remember, not forget everything else that we do and that we're responsible for in what we have to look for and evaluate for our patients. The astute dentist will have a trusted network of physicians as sources for referring non-masturbatory disorders. We'll talk about your interdisciplinary team as it relates to TMD patients. Complete dentists must be responsible for determining any masturbatory system involvement. That's the things we're responsible for. And if we can't load a joint, we'll talk about that quickly in a little bit too. If we can't load a joint, and by that we're meaning check its orthopedic stability, we need to find out why. Is it something from a tooth or is it a systemic issue? Remembering too that there can be serious medical conditions that are not, again, a dental problem or anything else. So just remember that bleeds, strokes, heart attack, hemorrhage, things like that, a splint's not going to fix these patients. Get them into the appropriate medical referrals. So let's look at occlusal muscle. Now, again, according to some of Pete's work that he did a long time ago, this is the thing you're going to see most common. Again, according to what Pete had seen, 90% of presenting TMD patients are going to be occlusal muscle, which is great because this is the easiest one for us to deal with. How are you going to figure out whether it's occlusal muscle or a joint thing? We're going to have to go back to the exam. So the complete exam is really the driving and foundation of everything we do with our patients. And we can do a clench test or anterior programming test, things that we do after the complete examination that helps give us some information. Your next most common are going to be intracapsular disorders. So again, it's your examination that's going to help you determine this answer. We use something called Piper classifications, and really all the Piper classifications are is a way for us to classify what's going on in the joint. I'll show you some images of that here in just a bit. Is it a normal healthy joint? Is it a joint that's partially displaced? The disc is off the lateral pole. Maybe it was an injured joint which is now stable and we can load and the occlusion's not changing. We call that an altered joint which is now stable. Or maybe it's a joint that's breaking down actively, or the patient's uncomfortable. That's not the patient that we're going to treat definitively with restorative dentistry. So our treatment on what we're going to do depends on that specific classification. So it's very important to have an idea of what we think is going on at the joint level. We tend to kind of back up a little bit and look a little farther outside and then go in. So we're going to talk about these categories of orofacial pain. So basically, if we think about what are all the sources or potential sources of pain from the shoulders up that could cause a patient to be symptomatic. We can have vascular, non-vascular pain disorders, primary headache disorders, neuropathic pain disorders, intraoral, TMD, cervical pain, extracranial and systemic causes, sleep disorders, and psychological factors. So there's a lot that's going on here. But if we look about what we can affect change on, it's 4 and 5, intraoral pain, tooth-related pain, odontogenic pain, TMD, non-odontogenic pain. And we have a role in playing with sleep disorders and airway. So that's not 100% in our wheelhouse, but we'll talk again here in just a bit. It's something that on the diagnostic side is becoming more and more important on the dental side, and probably something that you're going to just keep hearing a lot more about sleep and airway and how it affects dentistry, but not just that, but systemic health. And I think as the dentist, we are going to be on the forefront in diagnosing and maybe leading the way for health with our patients that might have airway or breathing disorders. We just have to figure out how it comes into play. So looking at orofacial pain, here are all the potential sources that we need to deal with. Is it odontogenic pain? Is it from muscles? Is it from joint? And again, with the joint, is it a partial or complete disc dislocation? Could there be an airway issue with our patient? Or is it a systemic cause? And those are really the questions that we have to answer with our patient, is which of these potential sources, or a number of these sources, because again, it's not necessarily one, it could be a couple or all of them that are leading to the problems with a patient. Most general practitioners can successfully treat the majority of patients that present with temporomandibular disorders once the concepts and treatment options are understood. Again, something that Pete's been saying for a long time, this is something that's very teachable as long as you'll take the time to kind of slow down, put it into your practice, and start looking at your patients this way. Again, I think the driver on most of what we do with these patients, and what Pete has talked about, his concept of complete dentistry, is to really just take the time to do a thorough examination. And that's whether it's a patient has aesthetic needs, functional needs, airway needs, TMD needs. The process is exactly the same. We're not changing anything for any of those patients. You're just getting different information by doing the complete exam. Henry Gremio, the dean at LSU, and one of the smartest people that I know with orofacial pain, has said that treating the orofacial pain is the thinker's game. And really, again, it's interpreting the data. But if you don't have data, which is, again, the complete exam, you don't have anything to interpret. So again, the driver to this whole thing really is just taking the time to do a thorough examination and then figuring out what that tells us. A couple important points here too is that treating the TMD patient is not an excuse for full mouth reconstruction. Once adapted centric posture is achieved, and that's a symptomatic patient that maybe had problems in the joints that was symptomatic that is now no longer symptomatic, so we've got them comfortable and stable. So once adapted centric posture is achieved, now we go through our same treatment planning protocols that we follow with any other patient. So, and we're not going to be doing anything irreversible on the symptomatic patient. So here's kind of the question. So why is it that some patients become symptomatic while others with worth problems are asymptomatic? It's not necessarily the degree of a problem we see, and what I mean by that is we can see patients, and if MI and CR have a discrepancy, it doesn't necessarily matter whether that discrepancy is slight or whether that discrepancy could be a couple or several millimeters. It's all about what the patients maybe do with their teeth in that discrepancy. The more they play with things, the more they can start to elicit problems. According to this study, the temporomandibular disorders, like many other diseases, have a multifactorial etiology, and the contribution of each factor to a particular set of symptoms is variable and differs from patient to patient. Here's a great description of it. Again, this was from a paper that Henry wrote in the Journal of Evidence-Based Dentistry, is that each person has what he refers to as this adaptive capacity, made up of these different factors here. And each of those can play into a patient becoming symptomatic or not. The psychosocial factors could be anxiety and stress, and they can have a negative effect on the patient. Abuse history could be in this. It could be a feature in somebody with TMD chronic pain. Gender discrepancies, females between 6:1 to 9:1 are more common. Sleep can play into something like this. It's necessary. Good deep sleep is necessary for health maintenance. And decreased sleep decreases growth hormone, and cell regeneration is decreased. Serotonin levels are decreased. We get an altered pain modulation as a result. But another interesting thing is that increased masticatory parafunction is at a level of 3 to 4 times more than waking hours due to reduced inhibitory factors while we're sleeping. Nutrition and exercise can play into this, and that gets related to the inflammatory process and free radical increase. And trauma. Interestingly, only 25% of TMD patients report a macro traumatic accident. So That could be a auto accident, a sports injury, or something like that, which means that the rest is more likely related to some type of micro traumatic event, which could be bruxing and clenching could be one. Once something throws that balance out, that's when the patient can develop pathology and start to get symptomatic. And this could happen at any time in somebody's life. But I think it's a great reason or a way for us to try to figure out is why all of a sudden does somebody become symptomatic when they've had this for a long time. All you need to do is throw one of these factors out of place, and now that patient is symptomatic. We used to deal with what I'll say is kind of 3 buckets of potential problems. And now we're adding a 4th. So, you know, things just tend to get a little bit more complicated. When I graduated dental school, all we worried about was the bacterial-based issues. Decay, period disease, endo, you know, anything bacteria-based. But then one of the reasons I started studying at the Dawson Academy was because I knew that wasn't it. And I was seeing patients with functional issues that were basically getting worse under my watch. And I was responsible for those patients. And honestly, I didn't really know how to best take care of those patients. So that's when I went to the Dawson Academy, and there's no doubt that I learned to better understand function and which patients had functional issues and how we needed to design long-term solutions and success. And then we kind of had the aesthetic wave, you know, looking at global macro and micro aesthetics, and that is so based with function. Those two go hand in hand. But now we have Airway. And Airway, honestly, is probably the most important thing because it's really important for our patients to breathe, and we can deal with the other stuff past that. And again, I think as time goes on, this next decade is maybe the decade of airway and systemic dentistry. The challenge to us is how you deal with these 4 different areas. And again, our patients can have none of these issues, one of these issues, or issues in every one. And if we do you have a predictable protocol to figure out if it's an issue, figure out solutions in a predictable manner for long-term success with the least amount of dentistry for every patient every time? Or are you changing your process every time you look at somebody? So in our opinion, you want to have a predictable process to take care of all of these patients, and it's the same for every patient every time. And that's where predictability comes in. It's interesting that the ADA just relieved this proposed policy statement on the role of dentistry in the treatment of sleep-related breathing disorders just a couple months ago. But one of the things they said is that dentists are encouraged to screen patients as part of a comprehensive medical and dental history. It's something that we need to do, children included. We'll talk about this again here in just a little bit, but boy, is it really important to screen children for airway issues and maybe prevent them a lifetime of more complicated problems. We know that if we start looking at airway and bruxism, so if we look at this TMD patient, you can't necessarily separate them from airway because a lot of TMD patients may have airway issues. So you have to screen for airway, whether it's a symptomatic patient, an asymptomatic patient, or certainly the TMD patient. But subtle respiratory issues, upper airway resistance and respiratory effort-related arousals are more likely to trigger a clench and grind than apnea and hypopnea. So basically what can happen is, why is somebody playing with their teeth? What's the reason for clenching or bruxing? Could it be related to a upper airway resistance or a sleep airway disorder? So it's something that we have to look at. We can check, depending on how far you want to go with this. Home monitors on the market today are used to monitor airway issues, but they can't detect some of the more subtle respiratory issues, but they're a great screening tool. What you'll find, or what I found as I started doing this, is I would have patients that I thought might have an airway issue, refer them to the primary care side of things. They have to go on the medical side for a polysomnogram or a full test, and many of them didn't want to. So is there a way that we can maybe do an easier screening without having to go down that route? And there are many ways of doing this. So something you're maybe already doing, you might want to look into. I'll show you that again here in just a minute. I keep promising I'm going to show you everything here in a little bit, so I promise I'll try to get to everything. Let's talk about malocclusion a little bit, because this is really interesting, and this is kind of where the airway issue is going. But if you've heard this term Darwinian dentistry, it's kind of interesting, is that if you look at these 2 maxillas, and I hadn't put where they're from down there, I would think the one on the right was the older dentition, and the one on the left was the newer, modern dentition, where all the great things we can do in dentistry is help preserve that patient's dentition. They have all their teeth, good arch size and everything else. The reality of it is the exact opposite, is that caries and malocclusion were rare in the pre-industrial skeletal and fossil records. And even today, it's seldom seen in many present-day non-Westernized cultures. The prevalence of malocclusion is several times greater than it was only a few hundred years ago. So what happened? I mean, that just doesn't make any sense when you think about it. But there's definitely this timeline on the pre-industrial time. So pre-industrial society, what was going on then? Well, foods required prolonged and forceful chewing. We didn't have processed foods. Children breastfed longer. Skulls were maxillary protrusive where compared to today. If we look at the post-industrial society, which is about 1760 to present, this is when diet changed to a softened, highly processed, fatty, salted, sweet, et cetera, and this is where malocclusion started. And not only that, but caries and periodontal disease are recent findings which coincide with the new diet. So since post-industrial, when diet changed to more sugars, more processed food, we lost that forceful chewing. We have been on a downhill spiral as far as dental health goes. If you think about current orthodontic cephalometric norms, which is kind of interesting, they're based on the 20th century norms. And remember, this is maybe a more reclusive, more retrusive skull than that pre-industrial. So it's kind of interesting that anthropologically informed cephalometric norms may be a better indicator of true genomic craniofacial growth potential. Now, whether our patients want to have a more prognostic look, that's something different. But it is interesting. It'll be interesting to see how orthodontics deals with airway and the setup of the face as it pertains to airway dimensions. If you look at ancient Egyptian skeletons, they revealed extensive wear but little dental crowding. Modern food preparation techniques spreading to the 19th century, so did dental crowding. Reduction on the forces of mastication is presumed to be a factor, and it supports orthodontic therapies that increase jaw dimensions. So maybe the paleo diet was pretty good, and where we are now is not the best. Maybe we have to alter this. This is a huge problem. We all know this in our country with people being overweight, sugars, et cetera, et cetera. So this is just, more of a byproduct of that. Healthy lifestyle is a good thing. Looking at self-electric evaluation of class 2 malocclusions in 8 to 10-year-olds, maxillary retrusion was common, but maxillary protrusion was rare. The skeletal retrusion was normally found with excess vertical development, that's that longer face. And as you get that longer face, it alters respiratory function. Altering the respiratory function then can cause a whole host of airway issues and growth issues. So there's a relationship between upper airway obstruction and the undesirable dental and craniofacial development. So let's think about growth here a little bit. So the back of the tongue is the front wall of the oropharynx. And during growth, the tongue moves up and forward during function and the airway gets larger. So think of the maxilla. We want a big, broad, wide maxilla. But if tongue movement is restricted, the maxilla doesn't form all the way and the airway ultimately gets smaller. The development of the maxilla is restricted, resulting in deficiencies in the sinuses, because now the sinuses aren't as large as they should be. The maxilla, the mandible follows the maxilla and then the airway. So in this is from Bite FX, but the tongue stays down. If you look at the upper right one here, the tongue stays down and then comes forward. So the maxilla doesn't go wide, it goes up and forward. You'll start to see malocclusions. So anterior open bite, high palatal vault. As that high palatal vault goes up, imagine what that does to the sinuses. You've got this anterior open bite, the mandible stays back, you've got that vertical grower, lips don't come together, they're breathing through their mouth. A whole host of things happen here, and all of them affect airway. If you affect airway on a growing person, all kinds of bad systemic things can happen. Here's a dissection that I did when I was at Henry's program. They have a great orofacial pain continuum. But if you look at number 2, that's the oropharynx. Think of the oral cavity as a box. And this is how I heard Whit, who's one of our faculty, describe this. And Whit's done a lot on airway and systemic health. He's a great person to listen to if you get a chance. But think of the oral cavity as a box. And the box is kind of outlined, the size directed by hard tissue, and it's filled with soft tissue. If you restrict the size of the box, where do things go? If the box is too small, the soft tissue is pushed back. If you push it back, it's going to restrict the airway. If the box is big enough, or we can change the size of the box to bring it forward, more room for the soft tissue. We're not going to be impinging on the airway. So think of airways a lot of times driven by the maxilla and how big that box is. And we start thinking about solutions, maybe also think about, for somebody with a restricted airway, is there a way to make the box bigger? Formation and position of the maxilla is a key element for proper craniofacial growth and airway. And the tongue is the critical part for developing the maxilla. So think about breastfeeding, because this happens early on, and what change we can affect here at the very beginning. But one of the things that breastfeeding does is allow and train the tongue to go up and forward as it latches on. So if a child doesn't breastfeed or can't breastfeed, they've lost that training to the tongue, which is then going to help grow the maxilla. So the breastfeeding promotes a correct swallowing pattern that allows for adequate growth of the jaws, and it ensures functional stimuli for proper facial growth and development. Now, it doesn't mean that every child that doesn't breastfeed is going to have developmental issues, but it certainly can be a precursor, which, I mean, think of it, this is right away after birth, that things could be happening that's going to affect growth, development, and ultimately airway on a child. A child that has a tongue tie cannot latch on. 20 to 40% of babies have ankylosing and they can't breastfeed. Speech, malocclusion, diet, TMD are all issues that they can see later on. Immediate correction is needed, and it's a very easy thing. Laser. There are people that you can get the child to. They just release that tie, no anesthetic or anything else. It's a fairly quick and easy procedure, and now that patient can latch on. And the lactation specialists are very good at identifying these issues. We are designed to breathe through our nose, not our mouth. And breathing through your nose is vital to good health. Nitric oxide is produced, which is not produced if we breathe through our mouth. And it helps prevent bacterial growth, improves the ability to absorb oxygen. It's a vasodilator, brain transmitter. It controls hypoventilation, increases red blood cell production, and unblocks nasal passages. If we're breathing through our mouth, those things aren't happening. So think about it as you're not running the air through a filter, which our body was designed to do. You're still getting oxygen, but it's like you're getting unfiltered oxygen, and we're not getting all of those benefits, hormonal benefits of breathing through our nose. If you look at children, adenoid hypertrophy is the most common cause of nasopharyngeal obstruction in children. As they breathe through their mouth, it can lead to formation of inflammatory response. Adenoid tonsils get bigger, they can get restrictive, they get infected. I mean, this child can't breathe. It's the most common cause of sleep disordered breathing, can cause altered craniofacial growth, long face, repressive chin, narrow maxilla, all those things we see with growth deficiencies. And taking the tonsils or adenoids out can solve some of these problems. Napoleon Dynamite, if you ever saw that movie, neither of these guys are breathing through their nose. They both have that kind of that classic long face. They can't get their lips together. They're both breathing through their mouth right there. So who's affected by this? There's really kind of 3 categories. Children, which we'll further subdivide. Young fit females, which is interesting because you wouldn't normally suspect that those patients would have breathing disorder. And coincidentally, that same category of young fit female, they're more commonly to have TMD symptoms, fibromyalgia, chronic fatigue syndrome, a lot of these kind of autoimmune problems. And then, you know, the overweight older male. Those are the ones we most commonly associate, but we can easily miss the other 2 categories. What's a scenario for a child maybe that has problems or altered breathing? And it's kind of a bad recipe here. Breastfeeding ends, maybe they're taking formula through a bottle. You get altered craniofacial development, allergy to dairy, nasal decongestion. Now they're breathing through the mouth, unfiltered air, tonsils enlarged, making it worse, difficulty breathing. They're getting decreased oxygen intake. Young child can snore. They start bruxing. They're not getting deep sleep. That means they're not getting that deep hormonal reparative sleep. They get a decreased release of growth hormone. Again, no deep restorative sleep. Cognitive skills are affected. They're sleepy and restless during the day. Now they get a diagnosis of ADHD and they're put on amphetamines. That is a horrible progression. And the treatment is to place a child on drugs. Well, what if you could affect change and help that child breathe? They don't need medications. They're going to be able to get deep sleep. They're going to be able to get reparative sleep. They're not going to be tired during the day. Maybe ADHD is not the right diagnosis. Maybe the right diagnosis is this child can't breathe. For dentists, the ability to identify these patients, the earlier the better, can have incredible long-term health results for our patients. The children, we break up birth to 8, 8 to 13, 13 to adult. And again, if we look at where they come into contact, birth to 8 is going to be the pediatrician, the pediatric dentist. They're the ones that have to kind of lead the charge on this. But there has to be some kind of airway examination, breastfeeding counseling, verify that the tongue mobility is correct and that we can breathe through the nose. And if airway issues are suspected, let's take care of it. Let's get early correction, maybe an ENT, screen for allergies. Believe it or not, ortho jaw expansion can happen at an early age. If we get to 18 to 13, again, we've got the pediatrician, the pediatric dentist, and also now the orthodontist is probably going to get involved. Same thing, you got to evaluate airway for all of these patients, verify that the tongue mobility is correct, they're breathing through the nose, start looking for normal jaw development. We start just looking at why all these patients have malocclusions, and we don't necessarily know the answer to this yet. But a lot of malocclusions, you got to start looking for an airway issue. Why did things not develop the way that they should? What's the reason? Maybe they need some type of sleep test or image so that we can actually measure the airway. And again, early correction, maybe the ENT, make sure there's no allergies, and early ortho. And the ortho is for jaw expansion. Phase 2 can be done non-surgically. But a lot of this ortho, again, remember the size of the box. Do you want to make the box smaller or bigger? So a lot of our patients should be having expansive ortho and not retractive ortho. I just see adults, so they kind of get to me when they're at this stage. You're going to go to the primary care physician and then us. We need to be screening for airway. We got to verify the tongue still. Can they breathe through the nose? Did something altered development in the facial profile? We need to get a diagnosis, and maybe it gets a little bit more complicated, but we can do home monitoring, or maybe they get a full sleep test. We're going to have to get involved on the medical side with their primary care physician, maybe an ENT or a sleep referral. We're maybe going to need to image so that we can see what the airway is with these patients. And diagnosis, reason for restriction of correction of options. Can we correct it or do we manage it? A lot of what we're doing on airway now is managing things. And our options for correction is orthodontic, orthognathic, or maybe perio-assisted orthodontics. So how do we deal with all this? And again, we talked about you need some kind of process. And this is, in a nutshell, our process, start to finish, for every one of these patients. Again, every patient, every time, regardless of what those 4 buckets are. We're not going to change anything for those patients. What we're going to do, though, is interpret what the examination tells us. But I want you to understand, too, that this is not about doing full mouth rehabilitations on every patient. Sometimes the solutions can be incredibly simple. It's solving our patients' aesthetic, functional, TMD, and or airway issues with the least amount of dentistry possible. And I told you that this exam is the most important part. We talk about records for success. And we're looking at joints, muscles, and teeth, and now more recently, we're looking at airway as well. It's a complete look at the gnathostomatic system, and you're just looking for a weak link in the system. We have the Dawson Diagnostic Wizard. We used to do this analog where we just use paper forms. Now we put everything in a digital format. Start to finish, every part of this complete dentistry process is in the Dawson Diagnostic Wizard. It simplifies everything. You can't miss anything from start to end. Wow, it's just really makes this process so much easier. That's the examination. I'll just talk about a couple parts of the examination. And this isn't necessarily changing anything you do, because I know all of us already are doing that bacterial examination. You're looking for decay, you're doing a perio screening, oral cancer screening. What we're adding on is that functional aesthetic and that airway evaluation onto it. One of the things that we do in this preclinical exam is just having a conversation with our patient. Some of these questions can lead us to trying to figure out if a patient has a problem and they're a symptomatic patient. Is it muscle or is it disc? And if it's a disc, is it partial or complete? This happens over and over again. And it's not necessarily one part of the test that leads you to everything. It's the totality of the test. And you being, again, something that Pete has said, being the physician of the masticatory system. And like Henry said, it's a thinker's game. What does that info tell you? And you can have these 7 questions and everything's fine, great, we move forward. Or it is a symptomatic patient, but just by asking the right questions before you've even ever done the examination on the patient, you can have some really good insight on whether you think it's a joint or a muscle related thing, and even whether you think it's a potential complete or partial disc dislocation. It's very powerful. We're always going to do an oral cancer screening. We just want to mention that because it's so important. We're going to check the muscles of mastication. Again, we use this scale for soreness and sensitivity. We do this co-diagnostic process where the patient knows what we're doing and why. Your assistant is part of it. So we're explaining what it is that we're doing. We're not necessarily talking about solutions yet. We're talking about comparisons to normal. But it's very important that the patient is part of this process. We're going to look for range of motion because we know range of motion can indicate a potential joint issue or a muscle issue. It's this great little ruler that we get from Great Lakes Orthodontics. And literally, we're just going to measure and compare to the norms that are right here. Nothing that is really difficult. And we record all of this data. We're going to do a CR load test. This is something, that Pete has perfected and, we've taught for years. Again, it's basically an orthopedic test on the temporomandibular joint. We're going to use bimanual manipulation. It's proper hand position. It's kind of a torquing motion, down with the thumbs, up with the fingers. And in essence, what we're trying to do is to just get the condyle seated in the most superior position. And you're basically going to do that by getting the lateral pterygoid muscle to relax. If you have a tight lateral pterygoid, that patient's not going to be able to get back into centric relation. It's not a forced position. We're not jamming the condyle anywhere. We tend to describe it more as kind of romancing the mandible. So it's, again, what you're trying to do is to get that lateral pterygoid to relax. Your force vectors are down with the thumbs, up with the fingers. We spent a lot of time in one of our early hands-on courses, the records course, on just practicing this technique. Again, like anything else, it's very learnable. Once you learn it, you keep doing it, your confidence increases. But it is not a difficult thing to do by manual manipulation, and then also to be able to get what we refer to as a centric relation bite record, because when we start our analysis on what we're going to do for our patient sets, where we want to start from. We're going to listen to the joint. We can use Doppler or JVA. Doppler is what we use most common. We're just listening for noises on rotation or translation. We're trying to get information that if there is a disc that's displaced, is it on or off? Is it on or off the medial pole or lateral pole? We have this information, we can get our diagnosis of a joint. We're going to look at airway. There are a couple of things that we look with airway. Malampani score is one. We're going to look at the maxilla, malocclusion, tongue, nasal patency, sleep position. We can verbally do, again, with the tongue here, you want to be able to stick your tongue out. And if you open wide, you should be able to hit your incisors with your tongue. Anything less than 60%, you have some type of restricted mobility. Look for scallop border. Is the patient tongue-tied? We can do a stop bang questionnaire, great quick screening tool on whether somebody might have a potential airway issue. We're going to look at the facial skeletal setup, especially from a lateral view. There's some tools that help us on the functional side of things. T-scan's a great tool. It records bite force dynamics, occlusal force location, and timing. I think it just ratchets up how accurate we are able to evaluate a patient and maybe even our dentistry. It's a great communication tool, good for case acceptance. It gives you force and timing, and it really gives us the ability to fine tune at a much higher level than just articulating ribbon. At the Dawson Academy, we use the T-scan. Again, you don't have to start out with this, but when you get to that level, if this is where you want to go, I use it as part of the complete exam towards the end. It just helps me, again, kind of show function for a patient. I'll use that as part of our treatment option review. I'll use it for splints, meaning I'll dial my splints in with the T-scan. I want to be as accurate as I can with my dentistry. Same with equilibration, definitive restorations, implants. It's really cool for implants because we know timing-wise, especially on posterior teeth, we don't want implants to come in first into the articulation because implants and teeth are different. They don't have periodontal ligaments, and it's a great follow-up tool as time goes on. So at the end of an examination, there's really kind of 4 things you got to answer. And this is, again, every patient. So number 1, what's it tell you? You're the physician of the masticatory system. So what does it tell you? The wizards summarize everything to this summary page. So it makes it a lot easier. We have aesthetic issues, functional issues, airway issues. You know, what is it? What are our problems? It's kind of cool because it auto-populates, and if there's a problem, it shows up in yellow or red. The next thing we need to be able to ask is, can this patient breathe or not? And that's one of the main things we have to answer. We have to be able to figure out what's the joint health. Do we have normal, healthy joints? That's that green joint. We don't have to worry about it. Is it the yellow joint that maybe problems are starting to arise? Or is it a patient that the disc was breaking down or the condyles were breaking down, but now we're in that adaptive centric posture? Our goal for that patient would be, gosh, let's set them up in an ideal occlusion. Let's try to decrease the factors that could make the progression of occlusal disease get worse. Or do we have this red patient? Do we have joints that are actively breaking down? A patient that's uncomfortable, complete disc dislocation. No definitive dentistry yet on those red joints. We got to treat the joints first. And what's our patient type? We kind of break our patients into 3 types. Number 1, there's no signs of instability. Joints are healthy. They don't need a lot of dentistry. It doesn't necessarily mean that they have a perfect occlusion. We can work in the patient's habitual occlusion, even if they need a little bit of dentistry. But generally, we don't want to do too much dentistry, and those patients don't need it. Those really aren't the patient that we're going to talk about going through all these other processes that we talk about. We'll call those the general patients. The next category, the second category, those are the patients that we see tooth, muscle, joint, or maybe airway issues, so that we've got tooth wear and erosion, but not bacterial-based stuff. They've got maybe tooth mobility, muscle pain, occlusal muscle pain, lateral pull issues. And we have a different process to go through with those patients. We got to start our evaluation in centric relation, mounted on articulator, centric relation, face bow, and then we're going to decide using really only the 4 treatment options we have: reshape teeth, reposition teeth, restore teeth, or orthognathic. I want to figure out what's the best way to solve those patients' problems. And then we're also going to have that third category, that red patient. And the red is for stop, meaning no definitive irreversible dentistry. These are patients that have complete disc dislocations or degenerative joint disease, meaning the bones are actively breaking down. And we're going to have to treat the joints first. Again, there's a process to take care of it, definitely learnable, just a different pathway for those patients. And we're going to describe these last 2 patients as your specialty patients. And that's really what the Dawson Academy helped me with, and hopefully could help you with if you're interested, is how to deal with these specialty patients. Back to the process again. Once we get the okay, we're going to try to figure out solutions. This is where it used to be. We had to look at aesthetic and functional issues and go through a series of pathways to help to figure out the right answers. But now we also have to look at airway issues. And in our treatment planning protocols, and we do this in the hands-on course, we've got to start thinking about airway. So we'll see those models on the right, or we'll see the patient with the wear and tear on their teeth. The teeth just aren't lasting as long as they can. And we'll look at it, we'll decide all these great things that we can do restoratively. We got to think a little bit, though, about the cause. Could it be the reason that that person had parafunction and played with their teeth was because they had that restrictive airway? So what they're doing at nighttime is, as they're gasping or trying to get breath, they're sliding their mandible forward numerous times an hour. And every time they do that, they're getting oxygen so they can breathe. We as dentists see it as wear and tear on the teeth and the teeth wearing out prematurely, but it could be due to an airway issue, and we have to be able to look for that. So we always think face, airway, bite as part of our treatment planning protocols. And if we need to test, again, how far you want to get involved in this is up to you, but the polysomnogram is the gold standard. It's going to be in a sleep lab. It's going to be on the medical side of things. It's certainly more expensive, but you can refer those patients out to primary care physician, an ENT, sleep center, however you want to do it. We've found, and I've found, that the home portable sleep study works great for those patients that just aren't quite sure. It's done at home. It's less expensive. It's a screening tool. It's not as accurate as a polysomnogram, but it might help the patient get there if it's able to show that there's a problem. They're read by sleep physicians. You know, we're dentists, we can't read it, and it can't diagnose central apnea, but it can do a lot. There's a whole bunch of these things on the market. This is one by Whitmix. I like to use this one, the DDME bruxism monitor. It checks for about 9-10 of the main things that we're looking for, certainly pulse ox, but it also is cool because it does check for mastication muscle activity. Very easy to use. Patient uses it overnight. Takes a staff member about 10 minutes to show them how to use it. They come in, we uplink it, then it's read by sleep docs, and we get a report back, much like a radiology report. And then based on that, if there's an issue, patients normally get it at that point. Now we send them off on the medical side. If it ends up that it's not an issue, you know, great, check that one off the box, something we don't have to worry about. So if an airway issue is suspected, then we're going to have to deal kind of with an airway team. Again, however you want to do this. Once a diagnosis is made, your treatment options, though, are you going to manage it or correct it? And only maintenance dentistry until the airway is corrected. We don't want to be doing extensive dentistry yet. So the goal of now treating this TMD patient is what we're going to refer to as comfort and stability, elimination of symptoms before irreversible dental treatment is performed. And this is for both occluso-muscle and intracapsular disorders. It's an interesting article from the journal in the American College of Dentists on ethical considerations in the management of temporomandibular disorder. And it says that research now clearly favors conservative and reversible approaches. I think our processes at the Dawson Academy, as I'm trying to outline, shows that this is kind of how we, I think, ethically follow things. We do not want to be doing irreversible dentistry until we can prove that there is a dental problem, occlusal disease, and that we can eliminate the symptoms, both comfort and stability, over a period of time before we start talking about solutions. And when we talk about solutions, it goes back to our normal protocols. If we need to restore, we need to do something, what is the reason for it, and what is our goal at the end? So here is the systematic approach, and I think this is the way we're going to approach every patient with potential TMD or airway. You got to start with the complete examination. So 4 things we just talked about a minute ago. What does the exam tell you? What's the patient type? What's the suspected TMJ health? And and can the patient breathe? If we think there's an airway issue, you got 2 options. You can do a portable home sleep study or refer for the polysomnogram. This has to happen first. We got to verify that these patients can breathe. If it's a TMD issue, we need to be able to make a decision. Is it muscle, joint, or both? And if it's a joint issue, do we think that it's a partial or complete disc dislocation? Those questions, a really, really good insight comes from being able to do that complete exam thoroughly and figuring out what it tells you. If we think that it's a bad joint, do we need more information? MRI and CT scan. We need a radiologist interpretation. We're going to start with reversible therapy, which we're going to call precision orthotic therapy. You got to choose the appropriate splint. Most splints are not appropriate and trade one malocclusion for another malocclusion. We're going to monitor our splints for comfort and stability. And if we get comfort and stability and to adapted centric posture, which means elimination of symptoms and the bite's not changing, now we can proceed with our 2D treatment planning. And if we don't get to adapted centric posture, you know what? Maybe it's not a dentally related issue. Think about all those orofacial pain components that can make a patient symptomatic from the shoulders up. now primary care physician, interdisciplinary team, but it's a refer for that patient. It's not a dental issue. Very important. TMD, again, is not an excuse for unjustified, irreversible dental care, and this includes equilibration or restoration. The role of us as the complete dentist is to try to determine if all of the pain, some of the pain, or none of the pain is from the masticatory system. That's our role. That's what we're in charge of. And remember, the pain can be coming from a number of sources. And if we can take one layer off and make that patient feel better, that's a good thing for the patient. We're going to do this in a reversible way. We're not going to start doing irreversible dentistry. If reversible treatment is successful and stable, then we proceed with our programmed approach to treatment planning, starting with 2D evaluation. And our goal is to solve all the problems that we can with the least amount of dentistry. Those two slides in a nutshell are what we want to do with these patients. And the complete exam and interpreting the data is essential to determine the presence or possibility of TMD. As we proceed then with our patients on actually now figuring out the solutions to their problems, we used to start this way, meaning you had to have healthy joints that we can load and that were stable before we would proceed. And if this was a no, you couldn't move forward. Well, now we've altered this a little bit in the last couple of years. Now we need two things to be able to proceed with irreversible dentistry. You got to have an acceptable airway, and you got to have joints that are healthy or adapted before we can proceed. A no on either of these means we're not doing the irreversible dentistry yet. You got to deal with airway or the joints before we can proceed. So we get two yeses, it's okay, let's treatment plan, let's go through our protocols, let's design that ideal treatment plan. But a no on either of those gets us to the now what? Here's where we are kind of currently with airway and apnea. So currently, you get proper testing and diagnosis from the physician, polysomnogram. Patient gets a CPAP. If it's mild to moderate, they can get a dental appliance. We got to titrate the dental appliance, make sure it works, sleep test again, medical billing, and a treatment. It's not really treatment, it's a substitute. Now, patient can breathe, that's quite all right. There are downsides on each of those, and we don't have the time to get into it yet, but any treatment can have negative effects, and both of those can have negative effects on the dental side. Maimonides was a Jewish philosopher, physician, and scholar, and one of the things that he said was the physician should not treat the disease, but the patient is suffering from it. What we mean by that is that the best we can do for somebody that has an airway issue? Just give them a substitute and not really correct the problem? Or is there something else that we can do? If an airway issue is suspected, the airway team is utilized for proper diagnosis. And once a diagnosis is made, treatment options are either management or correction. And only maintenance is done until the airway is corrected. I think as time goes on, we're going to be hearing as dentists a lot more about potential corrections for airway rather than just managing it. Hugely important for those three categories of children we talked about. And I think there's going to be a whole other list of potential protocols on how we can potentially make that box, the maxilla, bigger on an adult patient with a restricted airway. And I think that's going to actually be very exciting. So if we look at then airway issues, when orofacial pain treatment options, deal with airway, reversible dental care, systemic care if we need it, and then surgical intervention. Those are kind of the options. And if we look at the orofacial pain patient again with the airway, can the airway be improved or we just management? You're going to get sleep studies, maybe the ENT, ortho consult, surgical consult, CPAP, dental appliance.